Hi, everybody. My name is Rice, and this is...
I'm Kerry.
And we are from the Arc North East and North Cumbria, both based at Newcastle University. And today we'll be talking about our project supporting the NHS Long Term Plan, an evaluation of the implementation and impact of NHS-funded tobacco-dependent services. And we'd firstly like to acknowledge our funder, the ARC National Priority Consortium in Prevention, including behavioural risk factors. So this is our evaluation team. The project is expertly led by Professors Aquino and Ramsey, who I think are both here in the room. Hello, both. Give us a wave. And we've got 4 partner ARCs that are acting as evaluation sites alongside us, ARC West Midlands, Greater Manchester, West and Yorkshire and Humber. And we also have 4 other ARCs inputting intellectually and generously sharing their academic expertise with us, which are ARC Oxford and Thames Valley, North Thames, South London, and Kent, Surrey and Sussex. So I'll tell you very, very briefly, in the interest of time, the origins of this project and this topic that we're focusing on. So we have been working in close collaboration with the North East and North Cumbria Integrated Care System to identify some of their key research and healthcare priorities over the last few years, in particular the Treating Tobacco Dependence Task Force. With tobacco smoking being a leading cause of premature death and ill health, which obviously disproportionately impacts people living in poverty as well, and those at the intersections of that, including pregnant women and those with severe mental illness, as has been highlighted in several talks over the last 2 days. This tobacco dependence has been identified as a key priority in terms of addressing tobacco addiction and ensuring a smoke-free NHS across the region by 2030. And this is a priority that resonated with other partner regions, and it's something that we co-developed together along with our public group as well. So with, as a collective, we identified some key questions around the implementation of the NHS Long Term Plan, which is a strategy to address this problem. For example, how is this policy going to be implemented in practice, and what are its impacts on health and care? And what would be the cultural and attitudinal changes within the workforce and within the narratives around smoking and tobacco addiction over time? With that being said, our evaluation then aims to investigate the implementation of NHS-funded tobacco dependent services across 3 settings, so acute hospital, maternity and mental health inpatient, as well as its impact. I'm not going to read over the objectives, but I'll just give you a couple of moments to go over them. So for our evaluation, we developed a mixed methods design with 4 interrelated work packages. The first work package involving key informant interviews and document analysis. And this is really to better understand the implementation context. So where and how is this policy being implemented, and what services are currently in place, or what supports aren't in place as well. So really understanding that. And then we have work package 2, which is in 3 parts. The first part is a survey of healthcare professionals to better understand their perceptions of the delivery of this service, and this will be followed by in-depth interviews with them to understand their experiences of delivering this service and any barriers and enablers to doing so. We'll also be interviewing smokers to better understand their perceptions of this service and understanding the extent to which this is acceptable to them, but also understanding any barriers and enablers to accessing and engaging with these services. This will be followed by work packages 3 and 4, which are comprised of an effectiveness analysis, and this is very much aligned with NHS England improvements metrics. So we're looking at self-reported and or carbon monoxide validated quit rates at 28 days, as well as some process and service outcomes, including the number of patients that are identified or screened as smokers, and understanding the service offer as well as the uptake of the variety of services within this package, including nicotine replacement therapy and behavioural support. The health economic analysis will involve a cost effectiveness analysis based on a cost per quit, and I think that's that for me. I'll hand over to Kerry now, who will be talking about the preliminary findings from work package 1, which we're wrapping up.
Perfect, thanks, Bryce. So yes, work package 1, we are wrapping up. So, no, there we go, sorry. So this work package aimed to describe the implementation context that was in place before we rolled out the long-term plan. So this is a qualitative design, and we used interviews and document analysis. We hoped to sample 25 people from healthcare professionals, service managers, commissioners, and those at varying levels across all 3 of the pathways. And as it says, we did one-on-one interviews and we thematically analysed this. So we actually gained 23 participants from all 5 of the regions across all 3 of the pathways from very many different professions. And alongside that, we collected 31 documents, and these included trust smoke-free policies, ICS implementation plans, as well as the long-term plan itself. So from these findings, we have 4 main themes, and I'm going to quickly whiz through these, so I do apologise. The first theme is tobacco cessation services. So there's 3 sub-themes within this. The first being what was in place prior to the long-term plan, and is often described as being patchy. The second is how implementing the long-term plan differs between regions and what it looks like in different services, maternity, acute mental health across the different regions, and what the anticipated changes are, what they're hoping to see in terms of the effects it has on smoking, but also on staff delivering the service. The second theme is systems and infrastructure, and this is quite a strong theme within the findings, and this has 4 sub-themes. The first being data and data collecting systems, so very much the quantitative data, collecting smoking status, and this is reported to NHS England and improvement. Alongside that is funding and costing, so the funding that's being provided to trusts and the actual cost of delivering the service in both NRT and staff time. The third is collaborative working. Now this is really important and key, working with local authorities and trusts, as well as working with the ICS. And then level of support available. So again, this is how on board the trust itself was, the level of support that the trust was provided from their governors and their board of directors. And then the third one there is culture and attitude change. So again, this one has 4 sub-themes as well, and this was quite a strong theme as well. So the first one there is healthcare professionals' role and the boundaries of their role. And by this I mean the tobacco dependency advisors themselves. There seems quite a few barriers to them being able to fully fulfill the role. The second is COVID-19 and the effects that this has had on smoke and cessation service as a whole, but as well as the rolling out of the new long-term plan. The third is this idea that there's an increase in the work that's going to be required of the admitting teams and the pharmacists and doctors. And the final one there is the training that's going to be provided to staff, that most be mandatory or volunteer training as well. And then my final theme there is framing of the treating tobacco dependence. So this one has 3 sub-themes. The first being narrative, and this is this idea of medicalising tobacco dependence in the form that it's an addiction and not a lifestyle choice. The second there is strategies that can be implemented within trusts to help reduce the stigma when having conversations with patients about their smoking. And the third there is the impact of reducing health inequalities by implementing this new service. I'll hand over to Rice.
Thanks, Gary. So just to give you a brief overview of where we're at so far, Anne's given me a 2-minute warning. In the first year of this programme, we basically spent a lot of time doing the preparatory work to make sure that we're all set up and good to go once we had all of our relevant ethical approvals. So year 1 was really spent on doing that, and I'm sure that will resonate with many colleagues in terms of obtaining the right approvals and so on. We also made really good progress with Work Package 1, as you'll have seen. And more recently, we were able to obtain our REC approval, as well as what's called Confidentiality Advisory Group approval. And for those that aren't familiar with this process, this level of approval will allow us to extract individual patient level data for our work packages 3 and 4 without individually consenting all of those people that are identified as smokers and offered this service across the 12 trusts that we're working with in the 5 regions. So we're really delighted about that. And it's something that we've worked with our public network about, just understanding the ethical implications of undergoing that process without individually consenting people, and what some issues are arising from that. So towards the end of the year, we're really excited to be wrapping up work package 1 and starting on with work package 2 as we've got everything in place. So thank you, everybody.